will experience that. And that just goes to the stress of being in the environment, and it's just their way of trying to cope and just try. It could even be weeks down the line, and they'll feel guilty and they'll keep apologizing for asking the same question again. Or sometimes they won't apologize; they'll just ask the question again because they've just totally forgotten that they knew the answer. It's just how they're coping with the situation. But the things that we can do is, include them in the care. This is why we always need to, include the families, make sure they know that they're partners in care. They're not visitors. They are partners in care. They are it's their baby that we are supporting them to look after. And once they know that we're there in a supportive role and their opinion matters, um, they will probably be more observant on what's happening with their baby than we will, because we, from shift to shift, we might have the same patients 2 days in a row, but if the baby's a couple of weeks old, these parents have had that baby to look at, and that baby that they've been focusing on, that they've been seeing grow, and they'll know when the baby feels well, the baby feels unwell. So their voice matters on what exactly they feel is happening to their baby. So listening to their worries is also important. If we can alleviate them, because sometimes it just might be them thinking of the worst case scenario and the baby's well. But if they think that the baby seems unwell, and listen carefully, because they could be right. So now moving on to cotside care. What sort of how does handover? Do we all do cotside handover in our units? After you all have been allocated your baby, do you have handover by the cotside? Yeah, you can see
yes.
a few nods.
Yeah.
Yeah. And so does somebody want to unmute themselves and tell me the process of their handover? What information are you handing over? I know I'm cheating with the slides there, but how does your handover go in your unit?
The baby's name, how many weeks it was born, and the correct gestational age. If the baby was born by emergency cesarean cancer, can tell the reason, like poor CTG, like more of maternal cause, or the baby fact went for cesarean, like for fetal distress or for poor maternal effort. And then you can say what was done initially. Rescue breath was given, ventilated, and now baby is on vapotherm. Respiratory wise, is still requiring oxygen, maintaining saturation with this much oxygen, and then whether any work of breathing is present, and then first the respiratory part, then the feeding. If the tummy is okay, it is distended, or how are they tolerating feeds, how many meals they are taking, then how do they look? They are looking okay, like pink and perfused, and finish with the elimination, like baby passed urine, open bowel, and then to the medications, what they are on, like they are on antibiotics because they still have got some increased work of breathing, and yeah.
Yeah, and that's nice and thorough. Thanks, Angeline.
Thank you.
And I think that's important. Is there anything that Angeline said that any of the units add on, or what other things do you say?
Possibly what the plan is, what the plan will be going forward with Hope.
Yeah. Fantastic. Yeah.
What the ward round comments were.
Fabulous. Yeah. And also likes and dislikes. If you think, sometimes it'd be useful for say if I'm taking over the baby that you've been looking after, Nick, it'd be useful for me to know if you tell me, well, it's been noted that this baby doesn't like to lay on this side and lays more on that side. If you position them this way, this is what they like or don't like. Or if they feed, they've got their own bottles. Or when we fed them, we fed them with a slow teat, because they've been able to cope with it better, or they feed better side lying. So those things are also very useful, so we can have a steady continuity from with from one shift to the next. Fantastic, Teresa. You've just said about family involvement as well. If they're rooming in, that's also very useful when you're handing over. Because it'd be terrible if if the person that you've handed over to doesn't know that the family is coming in and they go ahead and feed the baby and the parents yes, and they go ahead and feed, and then the parents turn up and find that the baby's already been fed. Okay, so move on to the next slide. We seem to have nicely covered that. So, seems to have to go backwards on my slides. Okay, so for health, so this is all part of your health and safety. Alongside that, the things that we want you to be doing when you get to the cot side is, check for clear identification, as Rachel mentioned in her previous presentation. Check that the baby has their ID bands. Do they have their cot card? Do you have their weight documented appropriately? Are their fluids correct? Are they according to the weight? You're checking your drug charts as well, making sure that medication that was due to be given has been given when you're handing over, and you also know as the nurse taking over that as that shift continues, I know exactly what medications I need to give when. Everybody has a different way of trying to remember this information. I like to indicate it on my observation charts. I'll put little symbols, I put little M's to say when I'm doing my obs, at this point, this baby's got medication due, so I'm not going to forget that. But everybody does it differently, so I'm by no means telling you to do it my way. And you check your emergency equipment as well. So some of you might use neopuffs, some of you will use bag and valve masks in the nurseries. So depending on what you're used to, make sure you have the right size masks. You've checked that your oxygen and suction is working and that is clean. Because you don't want to be, if it's really grubby and it's been maybe never been used on your particular baby and maybe hasn't even been changed, make sure that it's clean. Otherwise, you're introducing bacteria towards this new baby that you're looking after. Those checks are also just as important. And then also you'll be cleaning your space as well as cleaning the touch points of your incubator. They get fingerprints, and even between shifts, the nurse that's coming in afterwards shouldn't really be finding my fingerprint, shouldn't be working and continuing working with my fingerprints all over the incubator. Because if we all just left each other's fingerprints, you know how the incubators get. It does start to look a little bit unsightly, but then with each smudge you're introducing, we all carry different bacteria through our hands. Even if we've washed our hands, if we touch something else, even after we've washed our hands and then touch the incubator, we may find we're introducing something new towards the baby or around the cot side. So let's just be mindful of our cot sides. And I will show you a video of how to check that your flow meters are working correctly as well. Because what is it that we check for when we're checking our flow meters? Who uses flow meters for the bags and masks? Yeah, Angela, you raised your hand.
Yeah, in KGH we use amber bag, valve and mask. Yeah, we have to check the oxygen on. You taught us on the other day as well to check whether the mercury ball is moving properly by occluding the oxygen. It should not because it should just stay there, and it should drop off. And then
Yes.
About the mask, it should be correct size mask covering the bridge of the nose and the chin. And when you press the bag, the pop-off valve should pop up, but not when using with the baby. just when you check for it. And the reservoir bag should fill when the oxygen is turned on to ensure the bag is free of any leak or any tear.
Yep, and that's brilliant. So I will show you that video actually on how to do those checks safely. There is a link as well in there about on safe on checking your neopuffs. For those of you that have neopuffs, there is a link for you to check how to safely check your neopuff. Um, if you're not familiar with it, at least it guides you step by step. So this is just an example of the cot side checks. So some of the eagle-eyed people who would have noticed, who would have recognized their own cot side checks. So the first one on the left-hand side, and I apologize, they're not very clear. The one on the left is from Kingsmill. Do you all recognize it? Sian and who else is from Kingsmill? Now. Can't really see. Yes, yeah, you recognize it. And this pretty much is just a checklist that you do every shift. Yeah, Laura, yes. Is it every shift that you check it? You're checking that their NGT competencies are done, your alarm settings have been checked, your medication, and it's just a nice prompt to show you that you've done the checks. Because there are times when you're doing checks, we know what it's like. You may get distracted while you're doing something. So at least while you've done, you know what you've checked, you can probably do like 4 checks, and then somebody talks to you. When you come back, you know, okay, I need to continue my checks. At least I've done that. And this is what's useful about having these cot side checklists. And this one on the right hand side is Kettering's, which is got similar information to the Kingsmill one. And this is and it does say for day and night shift, and it does show you it's at the bottom of the observation chart. So when you're checking your obs, then you've done your safety, then you tick off what you've had a look at and what you've checked on the baby. So infection control. Are we all familiar with our infection control practices on our units? Do you know who to call? Do you know who to call if there's what process do you follow if you've got an unknown or something that's new in the area? So say you've got a baby with rotavirus. What do you know the process you follow, or who you contact? Yeah, I could read Nick's lips. You did say infection prevention. You're gonna turn off your camera now, aren't you?
I'm not even going to put the thing on again. If you can read my lips, that's great.
I was trying to see anyone who was sort of saying something. And yes, you've got that team, but you've also got your experienced staff on the unit who may understand the procedure. You've got your guidelines, your guidance that will tell you the common occurrence of infections that you may have. It will clearly outline your procedures. So if you haven't seen that on that day too, make sure you at least have an idea of where this information is, because you don't want to be caught out on the day and you're like, well, what do I do? What do I wear? But always remember, on a neonatal unit, you're not working alone. You've got a whole team of people that you're working with, that you can contact, people that you can people that you can support you, and you can find the information together. There's always at least one person who's going to know roughly what to do. And if infection control, if you're not too sure, get in touch with the infection control team. Know how to bleep them. Where do I find their bleep number? You just need to know where those numbers are listed, and it just makes your life easier. Remember, you don't need to know absolutely everything. It shouldn't be written across your forehead. If I read Sally's brain, she's going to know absolutely everything. If I just look at her, she'll just tell me. Just remember that there are people that you can ask, so you don't have to remember everything. And this is why we have guidelines. There's no shame in re-looking at the guidelines. I know myself, when I do shifts, I still go back to policies and guidelines and read them. It doesn't matter how long you've been qualified, you can always go back to your guidance. That's what it's there for. As I said, make sure you clean your incubators regularly. You all have different instructions of how frequently you should change your incubators, and you also have you've also got a guide. You also make sure you've got your daily cleaning those touch points, as we've talked about. Your doors, your little handles that will be touched frequently. Sometimes milk's spilled. Sometimes baby's had a massive poo and it's splashed all over the incubator. Make sure those things are cleaned, and bedding. If it's there's been vomit, they'll wee sometimes, or you might just have them have an explosive poo and it goes all over the sheets. Just take pride in how you leave your babies. It doesn't always just look good, but it's also good for infection prevention, making sure that they have a tidy space. And just be aware of always have infection at the back of your mind when you're doing your day-to-day work. Am I preventing infection in the way that I'm looking after the babies that I've got in my care? So any questions? Okay. Hopefully that was all very clear. I will share this video. So the first one I'll share is the one with this will be the one with the flow meters. I'm going to do that again. Unshare first. It definitely needs sound, and I don't want you not having sound. Okay, just let me know if you can hear it when it starts playing.
No.
I can't hear you.
No sound.
I'll mute.
This is your standard flow meter at 0 to 15 litres. This would be found on most general wards. Moving along, we have 3 lower flow meters, which would tend to be found mainly in paediatrics, ITU and A&E. We have a 0 to 5 litre flow meter, a 0 to 2.5 litre flow meter and a half litre flow meter. And the last one is a high level flow meter at 30 litres. You might find these anywhere on the hospital, so the main priority for you is to be aware of what flow meters are behind the beds. Always ask the question if the flow meter doesn't look a standard flow meter. Testing a flow meter is very straightforward. You go to the unit behind here, you turn the flow meter on. It's irrelevant on where the ball sits. You occlude the tubing nipple at the bottom and the ball should drop to the bottom and remain still. If the ball is moving around, there is a leak. It's irrelevant on where the ball sits. However, when setting a flow meter, if you set it to 5 litres, the 5 litre mark should cross the centre of the ball. The ball should not be above or below. The reason we check a flow meter is for leaks. As oxygen is a drug, it's prescribed by the clinician. We need to make sure that the 5 litres is getting to the patient. By occluding the tubing nipple and the ball dropping to the bottom, it proves that any oxygen the flow meter is set to will go down the oxygen line directly to the patient, giving them the prescribed amount. Should the flow meter fail and you've checked it's inserted into the wall correctly and the tubing nipple is tight, your first point of contact would be the EBME department, and they would be able to replace with a like-for-like flow meter. Should you find a low flow meter, the test is exactly the same. However, because of lack of oxygen flowing through it, the response of the ball would be slightly longer. You occlude the tubing nipple, and as you can see, the ball gently drops to the bottom. As long as the ball remains at the bottom and does not move, this unit has also passed. Hi, part 2, suction, and we're looking at the different types of suction units. We have 3 different types. With the red and white, which is a high suction unit, which is found generally on most wards. We have the orange, which is the low suction, also known as low vacuum. This would be tend to find in paediatrics, A&E and ITU. And thirdly, we have the thoracic suction unit. This is used purely for chest chains only, and is the only unit that can be in use while unattended by a nurse. On the bottom of a unit is a pipeline protector. The pipeline protector protects not only the unit itself, but also the ring that gives you the suction throughout your hospital. Should that get contaminated, you'd be looking at a 24-hour shutdown while it's cleaned. These pipeline protectors are quite unique as seen here. When should these units be replaced? These pipeline protectors are recommended that they have an annual change unless contaminated. In a high use area, they recommend every 3 months. These would be in ITU, A&E, endoscope, somewhere like that. Generally, as soon as they change colour, this one here's got dust on, but generally as soon as they change colour, they should be changed immediately. The pipeline protector, or filter as it's commonly known, should also have a date on of when changed. How do we function check a suction unit? Looking at the high suction unit first, this is the basic setup. Your high suction unit with tubing going to the collection jar. In an ideal world, this would be yellow. However, it could be clear. The recommendation now across the country does seem to be that yellow tubing would be used. The reason for this is the outlet on the wall is yellow. The facial of the dial is also yellow, making the equipment side all yellow. And the jar liner is clear. The tubing going to the yanker is clear, and the yanker itself is clear. This should alleviate quite a few of the problems during setup. Okay, function checking a suction unit. If you take your clear tubing, making sure the yanker is safely stored, place your finger over the end of the tubing to cause a seal. Turn on the on-off tap and turn the dial, and the unit should reach a minimum pressure of 65 kPa. Keeping your finger on the end of the tubing, turn down the regulator to off, and the needle should remain exactly where it is. This will prove that there is no leaks within the circuit. However, if the needle drops away as so, you have a leak in the system. The first thing you would do is turn the tap off. Go to the jar and remove the yellow tubing, as so. Put your thumb over the yellow tubing. Turn the tap on and increase the pressure again. Must be over 65 kPa, and you turn it back down again. If the needle remains where it is, you have now proved that there is no leak between the outlet on the wall and the input to the jar. Therefore, your leak is within the jar or the liner itself. Should this happen, your first point to look at would be your bubble tubing. Bubble tubing, as you're probably well aware, has a large bubble in the middle of the tubing. When you take this tubing from your storeroom, you should cut at the widest point, bring it back to the equipment and trim it so the two tapers cause a tight fitting. If checking this doesn't work, you would then change your jar liner, and if the jar liner still doesn't work, change your jar. Always have a visual inspection and look for cracks, etc. if this fails. To remove a suction unit from the wall, place 2 fingers on the outer ring and push, and the unit will gently come away. Moving on to testing a low.
Okay, I will stop the video there. Has it brought up anything that people weren't aware of on checking the suction? I know something that I learned, I suppose, when I watched that video is usually when I was checking suction, I'll just check that the needle's going and I can feel the suction on the end of the plug. But as he said, that needle shouldn't move. It should stay. If you've gone to maximum and then reduce the flow and the pressure you've gone down to 0. That needle should stay in the place where it was at the beginning. It should stay at the maximum point. So that's something I know I just didn't know on the checks. But I do hope that video has helped you. What I will do is I'll probably send oh yes, Megan, yeah, you agree with me. I'll send the other 2 videos and I'll pop them in the group so that you can watch them at your leisure. But I do hope from what we've learned on this session that you're a bit more aware of why induction is important for both families and for staff. And when we know now that when you're familiar with your environment, you're more likely to engage better with your patient's care, and it reduces your anxiety, as well as it will reduce the family's and the parents' anxiety as well. Have you noticed that babies as well do pick up on the anxieties of parents? So in essence, it actually improves the baby's care because the baby will be calmer as well. They won't be as agitated as well. And then I hope it's giving you a guide into following the Kotsai process and why it's important to do so. At least then, one, it reassures you that you've done all the things that you need to do, not just ticking the boxes, but then you're giving that full holistic care and you're looking at every aspect of that baby's care while they're in your care in that period of your shift. And then also thinking about infection prevention. So I'm hoping that all these things have come through in the session that you have just had. Any questions before we release you for lunch? Okay, stop the recording.